First of all, we close the eyelids, stitching them together using a simple continuous suture with usually monofilament non-absorbable material. Next, we make an elliptical incision around the palpebral fissure using a scalpel blade, either a 10 or a 15 blade. You want to make your incision about 5 millimeters from the palpebral border. You want to make a full thickness skin incision. Once you've made your skin incision, you want to take your mitts and bounds and your rat tooth forceps to hold the skin surface and use a combination of blunt and sharp dissection to come down onto the outer surface of your conjunctiva. So the skin can be quite thick in some dogs, so you can have quite a bit to cut through. As you can see here, this is conjunctiva here, this pink tissue. So we've got conjunctiva here, you can see. Now our next stage is going to be cutting the ligaments. Our next stage is to cut the medial and lateral canthal ligaments to release this tissue. And the lateral one isn't quite as thick as the medial, so you need to sit here. So we're cutting through that now. And you'll find as you come through it, the tissue starts to release and come up towards you. Still working around outside of the conjunctiva. Next, we're going to transect our medial canthal ligament. This is a lot tighter, and occasionally you'll have to use the scalpel down onto the lacrimal bone because it's a very tight ligament. I don't know how well you can see. I often just use scissors to dissect down onto it. Very thick ligament. We're not quite fully through yet. And you're just continuing your plane of dissection at all times around the globe. There we go, that's the ligament there. you can see we've broken the ligament here. We're down onto lacrimal bone. Your next move is going to be to work around the globe, transecting the ligamentous attachments from your rectus muscles. So here is one here, so you can see we will just cut that. You're staying close to the globe at all times, working around in 360 degrees to loosen all the attachments. You just keep working from each side, loosening attachments as you go. And I use a combination of blunt and sharp dissection, so you can open up with your blunt dissection to see what's going on, and then have a wee look, and you can see have a look then for your muscular and tendinous attachments onto the globe, breaking those down as you go. And you'll notice your globe will become more and more mobile at all times, making sure you don't pull on it. You can move it from side to side, but very gently, but don't pull it towards yourself or put any traction on the optic nerve. Sometimes if you pull your eye very gently medial-dorsally, you'll sometimes be able to see your optic nerve caudally. Can't really in this dog. Our next step will be to transect the optic nerve and remove the eye. So you take your mitts and bounds round behind the eye and cut all your final attachments. That is your eye removed. So here we have our socket. We've got where we cut our optic nerve at the back here. In the live patient, you could pack this with swabs or lysostrips if it was bleeding, and wait a few minutes, and then you can try to ligate your vessels. But you can see we've got all of our extraocular tissues here that have been left behind that we're going to close during closure. All right, for closure, you want to do 2-layer closure, bringing together your ocular fascia and your subcutaneous tissues, and then you want to bring your eyelids together. This is easier in the live dog than it is in the cadaver. The other thing you always want to make sure is you've removed all your lacrimal tissue, so you've got out all your glands, because if you leave any, you may get cyst formation and sinus tracts forming because they're secretory. So you're just trying to pose the tissues that are in here. In this dog, there's actually not very many left. It's quite hard to see because of the state of the tissues. So as you can see in this dog, the tissues aren't coming together very well, but you're just trying to pose these to aid with healing and closure of the dead space in the socket as much as you can. Skin is then routinely closed with simple interrupted sutures. And that is us.